Wait. Line heading. End of the line is right by her hand. She's at the end of the line. Being a guard there.
As you can see, seizures are a common medical emergency. Hello, I'm Nathan Fountain. I'm a neurologist at the University of Virginia and director of the Comprehensive Epilepsy Program, where we take care of many patients with seizures and epilepsy. And the topic today is the treatment of seizure emergencies, which we'll concentrate on throughout our discussion today. The main objectives of our discussion are to first look at some acute treatment of seizures, and what I mean by that is when someone has a discrete self-limited seizure. We'll talk about types of seizures so you know what to expect when you come upon a scene, and also management of self-limited seizures. Then separately we'll talk about what I'm calling impending status epilepticus, that is, a long seizure that doesn't stop spontaneously and requires acute medical intervention. We'll talk about a new, shorter definition of status epilepticus or impending status. I'll briefly discuss a treatment algorithm for treatment of GCSE. And I'll use the term GCSE to make it easier for all of us. That stands for Generalized Convulsive Status Epilepticus, or one long convulsive seizure that doesn't stop. And finally, I'll end with some common pitfalls in the treatment of GCSE, Generalized Convulsive Status Epilepticus. We need to start with some definitions so we're all clear about exactly what we're talking about. The first thing is to define seizure separate from epilepsy. Seizure specifically is an abnormal behavior that results from paroxysmal, rhythmic, abnormal neuronal discharges. And what is meant by that is that paroxysmal is something that starts all of a sudden, continues, and then stops all of a sudden. In common parlance, we might call it a spell. Particularly in the South, we call it a spell. The abnormal neuronal activity, so the discharges in the brain, are rhythmic. They happen at regular intervals. It's abnormal, so there is some normal rhythmic activity in the brain, but seizures result from abnormal rhythmic activity. And these are discrete events or symptoms. In other words, a seizure is something that everyone anywhere would recognize. The common thing we think of is someone who has a generalized tonic-clonic or convulsive seizure, which they fall down, they jerk all over, and then it stops. That's as opposed to epilepsy or an epilepsy syndrome, which is really a disease entity. And it's anything at all that causes seizures. So although we use the term seizure and epilepsy synonymously, they're really not. They're different things. Seizures are discrete symptoms that you can see, and epilepsy syndrome is anything that causes that. It's characterized by the spontaneous recurrence of seizures. Of course, you must have seizures. But beyond that, epilepsy syndromes are also characterized by the typical type of seizure present, as we'll talk about, by a typical age of onset when the seizures start, and by a typical response to therapy, which is really the importance of understanding epilepsy syndromes. It's true that for seizure emergencies, we're not really very concerned about the epilepsy syndrome because what we're treating is the seizure, the actual symptom, although the epilepsy syndrome can be very important. Let's start by talking about acute treatment of seizures, or treatment of acute seizures, you might say. And the first thing to do is to classify seizures or consider the types of seizures that exist. This classification from the ILAE, the International League Against Epilepsy, is commonly used throughout the world. It was actually designed by Dr. Dreyfus, my predecessor. And the importance of it is that it gives us a uniform language that everyone will understand. And what it says is that seizures are fundamentally divided into those which are generalized versus those that are partial. Generalized seizures are characterized by having consciousness lost, that is, they're entirely unconscious during the seizure, whereas partial seizures have consciousness preserved, although it's not necessarily normal. Now you might say, why call this a partial seizure? And I don't have a good answer, except that among the people that described this, they couldn't agree to call it focal seizures, but I think any other person, most typical native English speakers, would probably call it a focal seizure, but technically it's a partial seizure. Now, partial seizures, I said, have consciousness that is preserved but not necessarily normal. When consciousness is perfectly normal, we call that a simple partial seizure. When consciousness is altered, we call that a complex partial seizure. And I'd venture to guess that complex partial seizures are the kind of seizures that people are most familiar with after generalized tonic-clonic. So let's look at some specific, or consider some specific types of seizures. Let's first talk about generalized seizures because they're probably the easiest to understand. You'll recall that in generalized seizures I said that consciousness is lost. Patients are entirely unresponsive during it. The most common kind of seizure we think of is a typical generalized tonic-clonic seizure. It's called generalized not only because consciousness is lost, but also because the entire brain is seizing at once, not just one part of it. During a generalized tonic-clonic seizure, the first symptom is tonic posturing, so the patient gets stiff all over, including their legs, and typically they fall over backwards, sometimes lacerating their occiput or the back of their head. After that tonic stiffening phase, they then become jerking like this, and that's the clonic phase. So clonic activity is repetitive, lightning-like jerks, typically of both arms and both legs. Now, a seizure could just be one part or the other. So some people have just tonic seizures, they stiffen and fall over, and they don't go on to the clonic phase. We'd call that a tonic seizure. Sometimes they skip the tonic phase and just start by jerking. All of a sudden, like this, become unresponsive, fall over. That would just be a clonic seizure. Some people just have a single jerk, a single isolated brief jerk. We call that a myoclonic seizure. Besides these kind of seizures that have major motor activity, there are also kinds of more subtle seizures that are more difficult to understand. In particular, there are absent seizures. During an absent seizure, patients stare unresponsively because their entire brain is having a typical rhythmic discharge. We call this a typical 3 Hz spike and wave pattern on the EEG. That's not really important while looking at the patient, but it's important to know that it's easily diagnosed by EEG and is a distinct kind of seizure. It's characterized by behavioral arrest. So whatever they're doing, they stop and stare. It happens intermittently throughout the day typically, most often in children, although it can occur in adults, which is a time that might be particularly tricky. I'm not going to talk about infantile spasms, which are brief jerks that infants have. So now let's turn our attention from generalized seizures to partial seizures and talk first about simple partial seizures, which you probably don't think very often about, but actually the easiest kind of seizure to understand. Fundamentally, a seizure is an electrical storm of the brain. What the person does depends on which part of the brain is having the electrical storm. And in a simple partial seizure, the electrical storm comes from just one small spot in the brain. So imagine that the electrical storm was coming from the right side of the brain, in the part of the brain that controls motor activity, controls movements of, let's say, the hand. That part of the brain happens to be in the frontal lobe, out far here to the side laterally. And when a seizure discharge happens there, it causes motor activity in the hand. So it might be, for instance, jerking of the hand. As long as that part's having an electrical storm, the hand is jerking. We call that a simple partial motor seizure because it affects the motor part of the brain. So you could imagine that if you have an electrical storm or seizure discharge from the sensory part of the brain, which happens to be near that, but just behind it, then instead there'd be an abnormal sensation in the hand, tingling or numbness or abnormal sensation. We call this a simple partial sensory seizure. Well, there's another part of the brain that controls autonomic activity. You recall autonomic activity is things like pulse, heart rate, blood pressure, sweating. And if this part of the brain in the temporal lobe causes an autonomic simple partial seizure, then people may feel a very difficult to describe sensation. They feel kind of an abdominal rising because their viscera, their guts are doing all kinds of strange things they're not used to, and their heart races and they may sweat or feel flush. We don't usually call it a simple partial autonomic seizure, although you could. That's really just a seizure aura. So when you think about people with temporal lobe epilepsy, for instance, who have a seizure aura, what they're really having is an autonomic simple partial seizure. And finally, let's turn our attention to complex partial seizures. In complex partial seizure, consciousness is altered but not lost. Another way to say it is that they appear to be confused. They're awake, but they're not interacting with their environment. They typically stare. They're unresponsive to questioning. Their eyes are open, but they're unaware of their environment. It's often associated with automatisms, which are automatic behaviors, things like lip smacking or hand wringing is very common. Sometimes it's picking at things like bed sheets if they're in bed, or sometimes it's taking their unbuttoning or buttoning things, sometimes actually taking their clothes off, or other kind of wild behaviors. Now, it's not really important to know about these different kinds of seizures except to know that they exist and to know that seizures can present as a whole variety of things. And the reason that's important is because if you're called because someone is acting with unusual behavior, one thing to consider is complex partial seizures. It's also important to recognize the different kinds of generalized seizures because by far and away, for a first responder, most people are going to be having a generalized tonic-clonic seizure, and they'll be all the way to the clonic phase. They'll be lying on the ground unresponsive, jerking. But it's important to recognize these other kind of seizures occur, particularly if they go in and out of seizure activity. So you recognize the beginning of the seizure when they get stiff and then go on to the jerking phase. And of course, the electrical storm could start in just one small spot in the brain and then spread or secondarily generalize. So something that starts as a complex partial seizure with staring and automatisms could then secondarily generalize by affecting one side of the body, getting stiff, and then having a whole convulsion. So let us turn to some examples. This one's an example of a generalized tonic-clonic seizure, and this one's particularly important. So in this case, this is a young woman in our epilepsy monitoring unit who's being monitored because we're trying to figure out where her seizures are coming from. And in this case, we actually want her to have a seizure so we can determine this. You can see that just before the seizure started, she was engaged in other activity. She stopped, she stared, in this case her head turned to the left, and then she has whole body stiffening. Now you'll also notice while she's stiffening that her left arm sort of externally rotates, goes out sideways and comes back in. And unfortunately she dislocated her left shoulder during this seizure as she had in the seizure just before it. So you can see she's actually wearing a sling over her left arm. So this is an example of a single self-limited discrete generalized tonic-clonic seizure because it stops. But in fact, of course, as a first responder, it might be ongoing by the time that you arrive. And this illustrates a couple of points. The first thing is just to demonstrate a single generalized tonic-clonic seizure, but also to illustrate how often injury occurs, like dislocation of the shoulder. You'll also see that they do some important safety measures that I'll talk about in a moment, which is mostly just roll her onto her side and make sure she's in a safe environment. So you can see padding along the bed rails, for instance, and that she's not someplace she'll otherwise be hurt. It's also really important to recognize here that we didn't do anything else. Nothing else was required. Didn't put anything in her mouth, didn't give her oxygen, didn't do anything else. And for an observed, witnessed, brief seizure, that's really the only intervention that's needed because by far and away, you're more likely to do harm than do good for a single, brief, self-limited seizure, as I'll talk about in a moment. Now we turn to an example of a complex partial seizure. So you can see that this woman is sitting in bed, she's talking with someone, and suddenly stops talking and starts to wring her hands. And these are the typical automatisms that I mentioned before of a complex partial seizure. The nurse is in the room. She eventually comes in and asks her name, and she's not able to say anything intelligible. Asks her to remember a color, which is our standard procedure. And then later on asks her if she remembered the color, and she doesn't. And that's because complex partial seizures of temporal lobe origin always impair memory. And you can see that immediately after the seizure, here's something really important. She tries to sit up and wander around. A lot of people might have to go to the bathroom. They might just feel like wandering. And you'll notice that the nurse doesn't restrain her. She lets her get up and walk around. She stays with her and makes sure that she's safe, but doesn't restrain her. Because often restraining people after a complex partial seizure in particular will cause them to be combative, when otherwise they'd be perfectly calm and otherwise cooperative. So it's important to direct them, to keep them safe, but not to restrain them. And this is an example of a very unusual seizure, a frontal lobe seizure. In this case, you can see this young man's laying on the couch asleep. Frontal lobe seizures often arise from sleep. He suddenly becomes stiff all over. There's a couple of important characteristics of frontal lobe seizures. One is that they tend to affect both sides of the body. So you can see that both of his arms are stiff. They tend to happen from sleep. And also, almost immediately after the seizure, he wakes up and he almost returns to normal. So he looks like he's just kind of getting himself together rather than having sort of a persistent confusion. So frontal lobe seizures can have bizarre manifestations, and that's the important point, is that sometimes people have this. Now, they're also often brief. So as a first responder, you wouldn't typically see someone having one long frontal lobe seizure, but you might see repetitive frontal lobe seizures one after the other. So there are several things that can look like seizures, mimics of seizures, or things that are commonly confused. So besides seizures, of course, would be syncope or fainting. During fainting, some people do have brief motor activity, but it's always brief. And of course, after fainting, people always come back to normal almost immediately, compared to a seizure where they're confused for a long time. Sometimes migraine headaches can present like a seizure because a migraine aura, when someone sees spots or dots, may look like an occipital lobe seizure that causes people to see things. But That usually wouldn't be a case that a first responder would be concerned about. And finally, pseudo-seizures. Pseudo-seizures are psychiatric phenomena. They're not epileptic seizures. Another word for them is psychogenic, non-epileptic pseudo-seizures. And these are episodes in which people fall down and thrash around, often with a lot of pelvic thrusting that might go on for 20 minutes or so. And their EEG is perfectly normal. So it's a manifestation of psychiatric disease, not neurologic disease. Rarely you'd confuse cerebral ischemia or a stroke with a seizure, because during a seizure people do things they wouldn't normally do. They're positive phenomena. Whereas during a stroke, people have negative phenomena. Part of their brain is not working, so they wouldn't be doing something. So this would be rarely confused, except that after a seizure, sometimes people have what's called a Todd's paralysis, in which one side of their body is paralyzed. And when it is, then they're able to use that side. And if you come upon them after the seizure and don't know that they've had the seizure, then you may confuse a post-ictal Todd's paralysis with a stroke. Sometimes movement disorders look like seizures. When they do, usually they're not part of something that a first responder would see. And rarely, of course, sleep disorder. So let's talk about the first response to a convulsion. So in other words, you come upon a scene and someone's still convulsing. There's sort of 4 basic things to take care of. And the very first thing to do is protect the patient from harm. That means from you harming them and also others from harming them and harming themselves. If the patient's standing or you happen to be there when the seizure starts, of course, you'd lower them to the ground gently. You'd remove all objects that they might hurt themselves on. So for example, if someone's having convulsive motor activity and they're doing this and they're punching the wall, then you should move them so they won't be hitting the wall. Or if they're abrading their arm on the carpet or their head on the carpet or banging their head on a hard object, it's important to put a pillow under their head or remove them from the place they're abrading it. You should loosen their clothing, because if they're wearing a tight tie like me, then they might actually asphyxiate, so it's important to loosen their clothing. And finally, don't restrain their movements. During a seizure, muscle contraction is maximal. It can be no more, because it's maximum stimulation to that muscle. And consequently, it's very unlikely first you'll be able to overcome it, and if you do, you're likely to hurt them. Patients break their own bones during convulsive seizures. It's common to get compression fractures of the spine, but also they can occasionally break a long bone. So you don't want to restrain someone during a convulsive seizure. After that, it's really the ABCs. So I've broken it down that way on this slide. So the most important thing